Blackboard under science, critical thinking 1. All right. You need to select one of the patients you were assigned to a clinical. It can be somebody you did this week. It can be someone that you had in the past. Make sure this person is interested, meaning using this patient, you will be able to address every question on here. Where students lose points. See this right here? A minimum of 5 points will be deducted for improper citations, APA citations within your answers. So this is where you lose your points. APA. That's at a minimum. This is a no-brainer. Your name. All that stuff does not change. It asked if there were any problems within 24 hours. If so, how were they handled? What were the nursing actions? Is the action in order of importance? Was the physician notified? What assessment data was gathered prior to notifying the physician? And then based on those that assessment data, what did the nurse do after that? Anything that happens in clinical, you can find support in IGI, you can find support in Potter and Perry. So if, say, your patient had a sudden spike in blood pressure, complained of shortness of breath, acute confusion, what could you probably think is going on with that patient? You don't want them to die yet. Hypoxia due to what? Shortness of breath, increase in blood pressure. What's the first thing you might think of?
What are we going to do?
What might be going on with your patient? Okay, could be respiratory aspiration. What else could it be? What else can cause somebody to become short of breath and their blood pressure go up?
Heart failure.
Heart failure. Okay, so let's go down the road of heart failure. So then, you know, the nurse will maybe say, this person was this, I called the doctor, I did this, or maybe I set the head of the bed up, I gave him oxygen at 2 liters. Then she called the physician and she gave him the assessment data and we received these orders. All that stuff you can find support for in your textbooks, okay? Don't go reinvent the wheel. We're not trying to find, you know, you and the latest and the latest. Stick to what you know is tried and true textbooks, okay? Any questions about that? What are two potential problems that could occur for this client in the next 24 to 72 hours? So this is why we quiz you guys when we're doing clinical. So look at your labs. Are labs trending? Are they trending up? Are they trending down? This is a good thing. Everybody is at risk for infection because they're in the hospital, so please don't put that one down. Look at your patient overall and figure out what two potential problems could occur in the next 24 to 72 hours and why. And then what nursing interventions should be performed to prevent potential problems.
On the first question, what if you identified a problem and you notified your nurse and they didn't notify the physician or they didn't do anything about it? How do you answer that?
You say that and say what you would have.
Okay.
And then find support for that.
Okay.
I need to repost this one because for each of your problems, for question number 2, oh here it is. You need 6 interventions for each. Where do you get your interventions from?
Panda.
Okay, actually, make sure they're what?
Specific to the patient.
Huh?
Specific to the patient.
Specific to the patient, yes, and cited. The way to get around that, you can say according to acne and acne, whatever the year is, 6 interventions for this patient would be. Put it in your block quote, and you give me the 6 interventions. Make sense? All right, do the same for the next one. These are 2 abnormal results. They can be labs, they can be tests, they can be procedures. Explain the possible rationale for the test. What are the normal test values or results? Are there any trends? This is another area where students lose points. You give me all of this subjective data, but no one ever gives objective. Subjective comes from where?
What you observe.
What you observe. So all your information, right? So the vital signs, the lab values, all of that. Nobody ever gives subjective data, which comes from who? The patient, to support these abnormal lab values. So if someone's H was low, what would be some subjective data you could elicit from your patient? Okay, I feel tired. What else? I'm dizzy. What else? If you're anemic and you're used to having a high activity level, what's going to happen? You're going to be tired, dizzy. What else? Headache. Headache, what did you say? Activity intolerance. Shortness of breath, maybe, right? Okay, these are the things that you guys should be getting from your patient. And then, according to these lab results, you need to figure out if there were any physician orders written and any changes in nursing care. So if I were you, I would pick the labs that are the most off the wall, that somebody really did something for, instead of you just picking two values that you are wrong. Make sure you find something that was significant in clinical, okay? This one also gets students very badly because you need to state whether your patient is should have a discharge or a transfer, okay? And you need to explain why. Also need to do teaching interventions or instructions and nursing interventions. How many of you have been a part of a discharge in clinical? Or seen a discharge? Or work in a facility where you know discharges happen? Okay. What must you do with the discharge from a nursing standpoint besides teaching? I got that. Everybody puts that. I know you're going to teach the family. You're going to teach them their meds. What else do you do as a nurse before you let anybody out the door?
Follow up appointments.
Vitals are part of your what? Oh, so vital signs and a what? Assessment. So you want to put that in your intervention. Everybody forgets that. They want to do the teaching. They want to do the follow-up. They want to say that they whatever, but nobody puts a physical assessment. So that's something we want you to get in your head. You do not let anyone leave your care without giving them a what? A physical assessment. All of this is going to make sense because you need to scroll down and look at number 5. You need to do a discharge summary in SBAR. Okay? I think there's an SBAR form uploaded somewhere in Blackboard. You can use that form to answer this question. So if you tell me that you did teaching and all of this stuff, and then I come down here and I see this big old in-depth, detailed physical assessment, I want to know how did you get from 4 to 5, and you didn't say that you did an assessment in 4. Make sense? So everything has to be sequential and logical and in order. Also, it says IV therapy, referrals, and follow-up. So if your patient has an IV and they're going home, what are you going to do with that IV? And where should that be documented before we get down here? And 4. So this is to get you to really start thinking like a nurse. What are all the things that I need to do? What are some things you can delegate? The nursing intervention, but you have the ability to delegate. So Renee said vital signs. Could you not say I delegate, vital signs, just see thing of the IV? What else can a tech do? Okay, thing of Foley to my tech. So then that lets us know that these things are here, they need to be addressed and be delegated. Yes.
I have a question. Anything that you're usually not supposed to finish yourself. It's not supposed to be like that. Is it okay for this project to say
APA, that's what I thought. You can refer to yourself. You can. And at first it was you could not refer, it has to be one or the person states or the researcher states. But it is okay to reference yourself. Okay. But do you not know you cannot use third person pronouns in APA format? Like she, he, we, they.
Say this
But you
patient.
can say I. You can say this patient or the family member third person pronoun. Please get this together now. We've got some time because next semester. Yes, ma'am.
When I did my remediation paper, how much it takes to have this high for EPA?
The last time I checked, you could. I'll check it again.
Yeah, she told me the same thing.
I know you can't use third person pronouns.
She said you have to say this author or this student or something like that.
As the student.
Yeah, it's corny, but.
Go look at Al Purdue again and see. Because the last time I checked, it was okay to say I, but not your third person pronouns. And they wanted to get away from that because it sounded so impersonal. Like you're writing you are the author, but it's like you're writing about somebody else, but you're really writing about yourself. So it's kind of like a disconnect. But just check Al Purdue. I'll do the same and make sure. All right, and then you must have your tried and true trusty dusty reference page that needs to be in APA format. Any questions about your critical thinking?
Do you want the cover page too?
Yes.
And it's due when?
We gave you a week. So it's supposed to be due when?
This Friday.
This Friday?
Yeah.
So it's due
Next Friday.
next Friday.
And it can be on any page that we've had in class.
Any patient you had in class.
Is our exam still next Friday?
Yes. Can't get out of that because that's before spring break. And I think you would like your exam before spring break and not after. Oh, it's not. It's not gonna say.
And are we still doing concept maps with this, or this is
This
separate?
is outside of all of that.
Okay.
So,
What are we doing this week? Concept map?
I don't know. That's for tomorrow.
Two concept maps. Concept maps.
Just concept maps and then your paper chart. So wherever you are with concept maps, I don't know, what is it, number 2?
Yeah.
This is number 2, right? So this is just taking concept maps. All right, any questions? Yes, ma'am. Okay, Al Purdue was just checked and it says that you can use I.
It says you can or can't?
You can use I. I will relay that to all right, any other questions, comments, or
Do you want a hard copy next Friday?
hard copy, please? Bring the hard copy to class. And
Okay,
I
today's
need two
gonna
of
be
mine
a
to
little
talk.
bit different. We're starting our neuro, and I'll be writing the whole test for the next exam. Anyway, it will be eye and ear, and it'll go over the disorders that we go over in class. There's a lot of neural disorders, but the ones that we're thinking about are the ones we're going to go over. And it'll be the disorders from the brain disorders today. On Friday, I'm going to finish up with like CBA and spinal cord. And then Tuesday, I will do the peripheral nervous system, which is about 4 to 5 disorders. All the PowerPoints are up. And what I do with neural is your PowerPoints, we go by the PowerPoints. However, I've learned over the years that students put the pieces together more readily if we do a demonstration. Making a segue to today, I'm going to tell you a little bit of information. Then I'm going to have Exhibit A from my stage people in clinical, and we're going to act out every disorder. And then we'll have about 10 minutes afterwards to bring in more information. If I say something more than twice, remember. With that being said, we're going to start off with types of headaches. Now, headaches, the medical term is neuralgia, or symphalgia, excuse me. Symphalgia.
Can you spell that?
It's on your side, but let me see. Symphalgia. Headache.
C-H-A-L what?
GI.
GIL. Okay. It would not be a test question. What's symphalgia? But you need to know that that is the medical term for it. There are three distinct categories for headaches: migraine, cluster, and tension. Now, for my clinical group, there is a person that has migraine headaches. Some of you may have migraine headaches. So you will have exhibit A with that. There are people who have cluster headaches, and a lot of other people have tension headaches. Migraine headaches is the classic headache that has an aura, A-U-R-A. Can someone tell me what an aura is?
It's almost like a visual disturbance. It's full of like flashes of light.
Yes.
And
Aura
usually
is-
not equal.
Aura is classically associated with visual lights in your visual field. It can also manifest with your hair standing on end. It can also be like tingly, like you use a shampoo that has a lot of something in it that tingles your head. It can be that. But classically, it's a visual type, what you described. Something in your visual field, like someone's looking and all of a sudden they say, I just see lights. Like someone hit your head and you see these visual lights. Okay. It's familial. It's inherited. It's a throbbing pain. And it usually can manifest behind one eye or the ear, the nerve root. Okay? Yes,
You said it's inherited? Like
it
genetic?
can be.
It can be or it can't be. Right? Either
There
way.
are familial tendencies. So if one person, usually female, that there can be the inherited predisposition to having migraines. It's not only females. Males can have migraines also. And we were right, and you're correct, that an aura is a sensation that signals the onset of a headache. It also applies to seizures also. The photophobia has to correlate with the light in your visual field also. There are phases. An aura develops. There's some type of neural dysfunction, the pain associated with any kind of concentration you have. You just can't stand it. Light in your visual field, certain stimuli that throws you from an aura, throws you into that aura. What are some things that would cause much neural stimulation?
Light.
Light, sounds, smells. Children, yes. Okay. The pain is preceded by, you have that aura, you have the numbness. There may be some confusion due to the level of pain. It may be the headache is so bad that you get aphasia, you have difficulty talking. And you're dizzy. You may have a cluster of these disorders or just one or two. Second phase, the nausea sets in. The nausea and vomiting. The pain intensifies, meaning that's more throbbing. So to differentiate the phases, Phase 1, there's an order. There's something that's stimulated that a headache to occur. Second phase, nausea sets in. You have the pain, the nausea sets in. And the intense throbbing. Yes,
Will you always have nausea?
not necessarily. The throbbing progresses to where you're just dumb. You have so much pain that you're just dumb. So, classic to migraines, there's the headache, which is the cephalagia, the nausea, and the vomiting. It can last up to 72 hours. That's like how many days? You don't necessarily have to have an aura, but classic too, if you were to differentiate the headaches, migraine has the aura. As you notice, you want to minimize the stimulus. Whatever caused the headache to progress, you want to help the patient identify their stressors. And migraines occur generally, early morning, but I've dealt with some people who have it manifested, middle of the day, and then a person. Usually associated with increased stress, EMS, or fluid retention. So someone, if they know it's fluid retention, what are you going to tell them to minimize in their diet? Salts, where there's the retaining of the fluid. What's going to help them if there's fluid retention? Huh? Maybe a diuretic if that's what they're on, or just kind of rest, because rest possibly, and there's going to be some medications that we're going to do. There are atypical migraines, they don't fit anything else. Someone can have a migraine headache for so long that the throbbing affects the vasculature, that the person has a precursor to having what? Stroke, blood vessel rupture. Migraine infarct, when you have the spasm that occurs, that first or where it's the constriction phase of the spasm, the person can become hypoxic in a certain part of the brain. And thus the degenerative changes mimicking a stroke. There are some nursing diagnoses, of course pain, and it's acute because it's happening at that time. The person can have a chronic condition, but there may be something that exacerbates that headache phase where they have the acute. Chronic, people can go from chronicity to acute exacerbation. Anxiety and hopelessness. There are some people, and I'll associate it with work-related disorders. There are some people who call in every month at work. I work in administration, and they'll call in, and I don't have much regard, but that's bad thing. But they truly have migraines. It's hopelessness. They're almost in limbo of losing their job because they're off from work. So these are people you would refer to FEMLA, where that they can not lose their job because they have a chronic condition that they have identified that could affect their job. You can't miss a lot of days with FEMLA also. It's to help. You guys know what I mean when I say FEMLA.
Mm-hmm.
Yeah. Someone explain.
Family medical leave.
Sasha.
It's a family medical leave that they have for you, like you need to be out for a certain amount, over a certain amount of time, and it kind of protects you, your job and your position.
We're going to do pain management or a board for preventative drug therapy What are some things you could have that person do? You already said to decrease the intensity of that pain. Dim the lights, rest. If they have a lot of stress, try to minimize that stress. If you need to get away from the husband, boyfriend, or whoever for a little bit, say, I need my time. Okay? Because you don't want it to exacerbate to a state where you're in, you have intractable pain. People are admitted to the hospital because they have intractable pain. Nothing seems to help it, so they have to be hospitalized to control that pain. You want to do the least invasive to help these individuals. And a lot of times you have to go to the medication management in conjunction. Drugs. We already said abortifacin. Acetaminophen. But what do we need to watch for if they're taking a lot of acetaminophen during the day? Huh? Toxicity. Toxicity. Okay. Where is it going to manifest if it's toxicity?
Liver.
The liver. So what are you going to see manifest by that patient if their liver is involved?
Jaundice.
Maybe some jaundice. The liver enzymes are elevated. Okay. NSAIDs, like what? Your ibuprofen. And then you also have, okay, let's start with your NSAIDs. What's some side effects from your NSAIDs?
GI.
GI disturbance, maybe some irritation to the mucosa, some bleeding. Okay, what about aspirin? What would you tell them to watch for?
Bleeding.
Huh? Tonight?
Oh.
And also bleeding that can occur. Ergotamine is one that helps them to decrease the intensification of the headache progression. Imitrex is one also. Beta blocker, how would that help?
Lower your blood pressure.
Lower your blood pressure, where you don't have that pounding going on. But if they did get a beta blocker, what might you notice about the pulse?
Go up.
Would it?
No, go down.
It's going to decrease the workload of the heart. What about calcium channel blocker?
Dilator.
Huh?
Isn't it dilator?
What I'm getting at is the same side effects that you guys studied relative to beta blockers and calcium channel blockers for your last test in farm and what you had when we had cardio, those same side effects you need to alert the patient. Selective serotonin.
Reputate inhibitors.
Huh?
It's reputate inhibitors, right?
Say it.
Serotonin, selective serotonin reputate inhibitor.
And that too.
I've had those for a while.
Okay. Anti-epileptics like Tegretol and Dilatin. Don't be like me, going there to the patient and they've been admitted with intractable pain, and they're on Dilatin and or Tegretol, and I go in and I say, oh, here's your medications for your seizures, and the patient's thinking, am I now having seizures? Those medications can be used for different reasons besides the seizure. Okay? All right. Yes.
So if someone's getting an
Convulsive.
epileptics, wouldn't they be getting that to prevent them from getting a seizure from the
Yes.
intense headache? Yeah.
It could be.
Okay.
Wait a minute. Say that again.
Because she was saying that the intense headaches can cause seizures, so would they be getting that drug to
Which one?
prevent them from getting seizures?
Not necessarily. Sometimes your Dilatin and your Tegretol can be used to help with the nerves.
Nerves, and we're going to get into that too.
Okay.
There's different reasons for giving these meds, and you need to look at it from the perspective of what's going on with your patient. involuntary therapies. If I had migraines, which I don't, you would not see me doing meditation. It wouldn't be meditation. It would be like prayer. Not just meditation. And yoga is out of the question. And I'm not going to have anyone put needles in me. I'm sure. But some people, it works. They can be calm enough to let it work. I can't. You know, relaxation techniques, the best way for some people to relax is get away from it all. A solitude, time to themselves. Some people, if they're by themselves, it intensifies everything because their brain's constantly going. They have A-type personality, or they got other conditions like they can't sit still, ADHD, they can't sit still, so their headaches manifest because that's their type of personality. Certain foods, what foods might bring on a migraine?
Chocolate.
Food,
Caffeine.
and then I found out others that it helps some people. Like if it's Professor Bethune, and I'm not picking on her, this occurs all the time. If you have her clinical, best thing you can do, make sure she has her coffee. Before she starts.
Or two. I think like artificial sweeteners can cause.
Because of the additives. So what would you tell a patient? You find what is the aggravator and the trigger, and you try to assist the patient in the decreasing the intake of that. Okay, cluster headaches is just that. It's related to a histamine that is released. It's not as usually occurring. However, you can tell it because it clusters. It's usually unilateral, one side, and it radiates to the forehead, can radiate to the temple or the cheek. There's tearing. With this one, there's tearing. Lack, am I saying this right? Tearing. What's medical term? Lack.
Huh?
Say it. Tearing. Lacrimation. Tearing. She'd say tearing.
What is
Okay.
lateral? Sorry.
Okay, ipsilateral, meaning it's that one side. And you have the running of the nose, the rhinorrhea. Ptosis, that's where the eye lid droops. Okay, and meiosis is with the eye too. The eye is not symmetrical with the unaffected eye. Tension headaches. Some of y'all have had that before in bed, right? Okay, maybe not. Neck and shoulder muscle tenderness, pain at the base of the skull or forehead, difficult to distinguish from migraine. But what doesn't it have?
The aura.
The aura. Okay.
But not all migraines.
Not all migraines have it. You have to be able to differentiate by seeking out medical assist. If someone had tension headache, if it's a mom, you know some of the triggers might be the kids, the husband, or both. Same way with the dad. If it is you guys, there are certain things that you know that trigger a tension headache. It could be that you're having an exam. It could be that you're going for a checkup. It could be all the above. It could be you're having a critical thinking paper in a week. It need not be. Okay. So, with that being said, I'm going to have to Exhibit A come up. You have to determine by what she's telling you. You're getting the intake from her. I want you guys to elicit questions to first determine. Bring her chair up. Okay. You need to
I'll take
determine
off back here.
what headache she had by asking her questions.
She's hungover.
Okay, pertinent questions. Okay, let's begin.
Lord of mercy, it's break.
Ask your question.
Migraine.
She looks like a migraine. Okay.
sometimes.
How long do your migraines last?
Depends. I've had them a couple hours to 4 days.
Family history of migraines?
None.
Are you sensitive to light and sound?
Yes.
You see aura?
Put the sunglasses on. I have auras sometimes. Sometimes I don't. They're like half circles in my peripheral vision that flash, and I sometimes will lose, I'll have light spots in my head.
What helps you the best?
That's a loaded question because what helps my migraines can also cause them. Sleep is usually the best thing for me, but if I sleep too much, it can cause one. Caffeine will get rid of my headaches, but if I drink caffeine, it can also cause my headaches. I got one yesterday. Something else that's kind of interesting, I don't know if this is related, but my pupils are different sizes as well. April noticed it yesterday. She's like, "What's wrong with you?" I was like, "Yeah, I'm getting a migraine. I always get them on my right side, and my right pupil gets smaller." Yes.
Do you have allergy or sinus problems?
I have mild allergies. I'm always sniffing and stuff, but it's not. I don't take anything for it.
Have you seen anyone with your allergies?
No, they're not severe enough. It's just a sniffle. Like I'll be like this for a few months.
What are your sleep habits?
My sleep-wake cycle is weird. I work nights at work, and I'm here during the day, so I'm all messed up.
You have no sleep cycle.
On that note, I can throw my triggers in if you guys want to know. Lack of sleep is my biggest one, and stress. So nursing school, I get them about a week before the exam. I'll have a migraine every day for like 4 days, like Wednesday, Thursday, Friday, Saturday. Caffeine can cause them. They can also get rid of them. Artificial sweeteners, you mentioned. I can't drink anything diet at all. Any sugar-free stuff, I can't do it. MSG, beef jerky. I love beef jerky. Can't do it. Odors. I can't stand cinnamon, vanilla, pine. Candles. Don't buy me candles. Loud noises, bright sunlight. I always have sunglasses on me. Always. I have 2 pair in case I lose one. Cold air. Those are my big ones.
Did you get any medications?
Nothing really helps. I don't get the throbbing, which I'm very lucky. I don't have throbbing, debilitating pain. It's just like really annoying. The light sensitivity and the nausea are worse than pain for me. Really, the only thing that even takes the edge off is I'll take 2 ibuprofen, 2 aspirin with a big cup of something.
Liver enzymes?
I don't even want to think about it. Yeah,
Have you tried exercising?
I do exercise, but when I have all of that going on, I don't even want to think about exercising at the time. But I have been working out more, and they have been getting less frequent.
Do you consume alcoholic beverages?
I don't drink at all. I don't smoke.
Have you ever tried a maintenance pill for your migraines?
I've never, they've never been bad enough for me to, because they don't really hurt, which is kind of weird. It's not bad enough that it, I don't really like the side effects from what
I take a maintenance pill.
Do you?
But I have to take it right before I go to bed because they make me a little drowsy.
Oh, yeah.
So since I do the nights and the days with school, I have to be careful with it. But they
You're like me. I thought about it, but
it reduces them a lot.
Have you seen a physician be diagnosed with migraines?
I have been diagnosed with migraines. I got my first one when I was 14. I thought I was dying because I couldn't see. I lost, it was the most horrible headache I've ever had in my entire life. I fell asleep and I didn't think I was ever going to wake up. I didn't have one again until I was pregnant with my first son, so it is hormonally related as well. And I thought, I'm like, oh my God, so I'm dying again. And then I remembered, and my doctor, I went in and he goes, you've got migraines. I'm like, but my pupil thing's kind of weird. That kind of throws people off. I've had, they've checked my head out. I don't have glaucoma. I don't have any stuff on my head.
Okay, so bring her together. She's told you. Anyway. The triggers.
Don't
She
cry.
told you some of her triggers. The stress. She says non-medication caffeine helps it, but it can also exacerbate it. Did she say you had nausea?
Not usually. Sometimes.
Okay.
It's really sporadic.
And she says hers lasts how long?
Couple hours before.
Huh? Almost 4 days. Okay. Then it just dissipates.
Yeah.
Which goes, it goes away. She says the most intensity is before exam. Okay. And it lasts, it just keeps up. The main thing about it is, she said when she first started getting the migraine, what did she lose? What sense? Her vision. And with migraines, you can have an aura, but you necessarily don't.
I get like flashing, like half circles in my peripheral vision, and sometimes I'll get the spots, but
Like if you stare at the sun and then close your eyes, that kind of like.
Huh?
Like when you stare at the sun and then close your eyes and open them and all those dots.
kind of the same thing,
Is
yeah.
that what it's like?
And it's always in my peripheral vision, which is annoying as heck because I'll go to look and it moves. And it's always right here. It's, you know.
I've heard of I had a doctor tell me I had this after I had my son, ocular migraines. Have you heard of that? Where like I
Or
would,
some stimulus. A stimulus? Certain
yeah, I would get like a big black spot in my vision, and I thought it was just in one eye. But then if I closed that eye, then it was the other eye, and then kind of it would come with a little bit of like disorientation or confusion, and then it never really got a bad headache though. I would kind of get like a little bit of a headache when I went to the doctor, and they said they thought it was I don't know. They took me off contraceptives, so I wonder if they thought that it was like clotting or I don't know what they thought.
Okay, so it's the question.
So is the distinguishing factor going for symptoms?
Well, it went away.
It seems like she has
After that, I think they thought I was having like
There's a question up here that is there a distinction which would associate more so with migraine? The duration of time, yes.
I don't always get auras, but I always have light sensitivity. So, always.
It's like that was a test.
And noise, like it's so loud.
I'm going to tell you, and I've said it 3 times, migraine you associate it predominantly with aura. You don't necessarily have to have an aura, but it affects the senses.
The tingling.
Okay, thank you. Let's move on to seizures. And then what we're going to cover today is headaches, seizures, Alzheimer's, and Parkinson's. Okay. And seizures, there's a difference between seizures and epilepsy. Now, seizures can occur for various reasons. It can be with a young child, it can be a febrile brought on by a fever. Seizures can be due to hypoxia, not enough oxygen. The person does not have enough oxygen as a result of they stop breathing, or there's some vascular impediment of blood flow, oxygenated blood. Seizures are a condition within epilepsy. Epilepsy is a disorder. Seizures is a symptom. I'll say it again. Epilepsy is a true disorder in which seizures occur. Seizures are a symptom. Many of you have seen young children and they're in school and you notice that they are prone to seizures. And they have them often. And they may have some other neurological manifestations. That condition is epilepsy. They have seizures and some other neural manifestation that occurs. And they've been diagnosed by EEGs and various neural diagnostics to determine that they have epilepsy. Okay. There are 3 categories of seizures: just generalized seizure, partial, or unclassified. That's background. What you need to know is there are 6 types of generalized seizures. Tonic-clonic, where both of those conditions are going on. Tonic or clonic. And that is like this. Tonic is you're looking at somebody and they're just stiff. Clonic is they're having convulsions along with that stiffness. Both are a problem because what system is affected if they are just toning up real quick? Huh?
Respiratory?
Respiratory and their balance. Everything is affected. Okay? But mainly respiratory and musculature. Absence means someone's there but nobody's home. Like for instance, you'll see this in young children that they have to be diagnosed with it, or that I've seen it when working with some young children. They're in class, everybody else is paying attention. They just come in from PE, which they don't have too much anymore. But PE, they just come in from PE, and this person's just, the lights on, nobody's home, staring. Yes?
My daughter has that, and I have to actually walk up to her and shake her to get her to.
And then when she comes out of it, she's wondering why you're shaking her.
She gets a nystagmus and a nervousness in her eye after it happens too.
Right.
When I was a PE teacher, I had a second grader that had a seizure. She was epileptic, and I didn't know that as being a PE teacher, she had a seizure. And she was just like, they said that she was like weird all day, like she's not there. And then we went to PE and we fell to the ground. We thought she was laughing and tagging. She was seizing and just throwing up and everything. And then it scared me. We took her temp right away. It was 103, and then the EMS came. It was scary.
It's best to follow up with EMS because you don't know exactly what all is going on. So, absence. And the difference is this person is there. They may not have any convulsive effect or tenseness, but nothing's going on.
So that's more with children. It's not really with
It can happen in adults, but predominantly children. Myoclonic can affect either side. Either side. It can be just one hemisphere, where it's musculature, where the person may have a twitch.
Can you say that one? Either side of the brain? Is that what you're saying?
Huh?
Is it either side of the brain or either side
It
of
can,
the body? Or
okay, well, it affects the side of the brain, but it's manifested on the opposite side. You understand?
Mhm.
Just like a stroke. It might occur, the electrical synapses are so frequent, but it'll manifest if it's on the left side, it'll manifest on the right. The myoclonic. Atonic is someone just, all of a sudden you're talking to them, and they just go limp on you. They're not aware of anything going on. Just limp. And they lose control of all body function. Tonic-clonic and atonic, they lose control of body function. It's predominant. You can with these others, but it's predominantly with tonic-clonic or individual by itself, tonic or clonic, and atonic. Because if they're atonic, they don't have control of musculature.
I have a question.
Yes.
About seizures. I've had a conversation that the nurse would say they're faking their seizures.
Most of it can.
And if they're truly having a seizure, they'll sometimes get an aura, but they don't really know when they're going to get one. A patient that was their call light and then have a seizure. And it's just, I hit my call light because I knew I was going to have a seizure.
Yeah. In case in point, I've had many of patients, their light has been going on, and they didn't get the nurse in there, so they make a seizure. So to get people in there.
That's
You know,
awesome.
Can you ever like know that one's coming off? Like,
you can know
you
if the
feel
seizure
like the
comes on.
symptoms?
Well, the aura. They give the aura.
And the people can learn what are some auras and
And
fake
they're
that
triggers.
auras. It can trigger. I'm telling you about people who ain't right and do. They try to fake it.
Well, the nurses are telling me that if they were having a true seizure, you can walk up to them and they won't be able to pull their chin down. But if they're faking it, like I walked up to a lady and I went over her chin and I kind of like, this was not my thing. And she was all flopping around and she was spitting and it made this big dramatic.
And the eyes is the other thing, right?
Yeah, they'll have some sadness or something. Okay. Tonic seizures. The person may have an aura. It usually lasts 2 to 5 minutes. What would you think you need to do for this person?
Patient safety.
Patient safety. If they're in harm's way, you get them out of harm's way. If they're about to fall, you're going to take them to their, put them to the floor. When we act this out, the patient is not going to go to the floor. Okay? There may be some rigidity and stiffening. You don't want to constrict anything. So therefore, you want to loosen clothing if need be. You want to protect the head. Airway, protect the airway. So basically, if this person falls and they're not breathing, what are you going to do? Maintain an airway. Try to open up that airway without force. Open the airway, protect the head. Okay? While you're doing that, you might have someone call EMS. Okay? The person is not aware of anything. Don't try to ask them anything.
Are you okay?
They're not okay. Okay? And they've lost all control, and that means all control. Okay? They may become incontinent. Bowel and bladder. Okay, when they're coming out of the seizure, they're going to be lethargic. So you need to protect them then. They're going to be confused, asking, what happened? This, that, and other. And depending on the neural level of that person, that lethargy, the fatigue, may last an hour. What may have perpetrated that person to go into that seizure is they didn't take their medication. They're not eating, so they didn't take their medication. Or they're taking a medication that decreases the effectiveness of that. Yes.
Say you have like an elderly person and they've been on NPO for a certain amount of time and they usually have can being NPO or dehydrated cause the seizure?
Yeah, whatever the trigger is. But in that case, we can give it IV. We can give that medication IV to keep up that therapeutic level of the tegretol of the diabetic.
What did you say the last time the medication was not effective?
Certain meds will, if you think of it basically, if someone said their stomach was upset and they took their Dilatin and they took an antacid, they put antacid, you know it's going to decrease the effectiveness. At the same time, you need to watch the other end of the spectrum. If someone is on tegretol or Dilatin, which are anticonvulsives, anti-epileptic meds, if it's someone of childbearing age and they're taking birth control, oral birth control, these medications decrease the effectiveness of the birth control. So what do you need to tell that person to do? Yeah, watch out by doing what? Using another method, which is barrier, creams, or all the above, or abstinence. Okay. Examples of tonic-clonic. Tonic phase, clonic phase. multi-phase. Okay. Absence. They may have thought I had absence seizures when I was in school, but I was just pissed and upset with them. The thing is, but the lights on, but nobody's home. And then the instructor would say, Vivian. And I heard what she was saying, but it didn't register. I got out of bed. Okay. Myoclonic, we said, it can be stiffening, jerky, a certain hemisphere. It can be in groups. That it can be special arrangements.
Question, how is that different than the tonic-clonic?
Because it's a hemisphere. It's a cluster of areas. Tonic-clonic is whole body.
Okay, so this one would only be on one side of your body?
Or a group of. You would notice that the whole body is not in that clonic.
So like both feet?
Like what someone's going like this and just, one side.
Their whole body?
Yeah. Atonic seizures, the main thing with these, the person just goes on it. I'm up here, I'm giving a lecture, and all of a sudden I'm looking at somebody, someone stressed me out. I'm looking at that girl, and all of a sudden I just kind of go there. I might even fall. Let me stay there to EMS gets here, okay? If that's okay.
You know what
But
post
they're at risk for fracture and everything.
what is post-ictal?
What's post? What's
After?
and what's post?
Post-ictal is your after the seizure. That's the term that's used. It's right there on your slide. It says post-ictal confusion.
So after a seizure, a person's going to have a post-ictal phase. Partial seizures are just that. Localized seizure, it's sometimes associated with myoclonic, or it's just one muscle group. The ones you need to remember, and I'm going to go through the rest, is tonic, clonic, or what are the other tonic or clonic, absence, and the layman's term that we used to say is grand mal seizure when it's a total body. Grand mal seizure. That's the tonic one. I'm not going to go into these others. Would you be quiet? There are approximately, it's more than 2 million now, but I think the slides have been researched that were entering for 2.5. In certain areas of the country, epilepsy is more prevalent by virtue of their water sources, their food, their availability to healthy food, the environment, whatever in that environment that affects the nerves. 80% are controlled with seizure meds, your anti-epileptic. What you want to do is obtain history, and that's with, like we did with what you did with headaches. Anybody else in your family have headaches? You need to ask. When did your headaches start? Describe when did your seizures start? Describe the sequence of your seizures when you have them, what you've been told the person is. What medications are you on? Do you get serial therapeutic levels of your meds, be it the dilantin and the tegretol? What dilantin and tegretol does, it decreases the seizure, it increases the seizure threshold, meaning you don't go into a seizure rate.
What was that called?
Seizure threshold.
No, the medical.
There's others, but those are ones. So, you want to know meds, history, and are they taking any other meds, which might interfere with the absorption or exacerbate another med if someone's under control. Assessment is what you do with any patient, total body assessment. You want to assess the onset. If you come upon somebody, you want to assess the onset of that seizure. Did they lose any? Did they, as far as when did it start? What were the manifestations relative to the seizure? What happened in the postdictal phase? Was there confusion? Or did the confusion dissipate? And what you did relative to that seizure. You call EMS. How did you support the person? If it's outside, if it's in the hospital, what did you do to? What med did you give? What med would you give to bring someone out of the seizure? What's going to help reduce that anxiety in that girl?
Like a muscle lock?
Ativan. If to bring them out.
How would you give that Ativan?
Push.
Okay, just check.
What is it, IV?
IV, and if you don't have an IV route, then you're gonna have to give it IM. For anybody that you know has a seizure, I would think and hope you would make sure that they have IV access.
Okay.
Specifically out of that, or could it just be
It could be any relaxant.
any kind of
There's
anxiety?
anti-anxiety meds, but the one predominantly is Ativan. Okay. What you do for one seizure, you protect, you do it for all. Okay. This is what you do. Don't give the time in slide 33. Reduce environmental stimuli. If it's a family there, tell them to come back later. Let the person rest. Pad rails are controversial because there's been some people that have gotten stuck in the pad rails, or they suffocate into the plastic part of the side, the padded side rails, and it becomes them where they don't get enough oxygen. Keep the bed in the low position. You don't want them to take a tumble from way down. You want to have her lock. Why? Because you're going to bring them out of that seizure, you're going to be given IV with med. Suction, because they lose control of secretion. And supplemental O2. You don't put fingers or airways or anything in that mouth. Bite blocks or anything. It says take oral airway to the head of the bed. That is if you're in a hospital setting and this person is not breathing and you want to really know that it's only a seizure coming in, all this stuff is going to be in a code card. If you're at a mall or something and this person has a seizure, it's not the time to be trying to open that mouth. You're positioning the head for facilitating O2, but you don't put anything in the mouth. Because those teeth are down, and you don't want to lose a digit. That's the main thing there. Let's take a break, about 5-7 minutes, and my crew is going to be up here.